this is what happens. That this is that osteomyelitis. With that, there is effusion, and radiologically speaking, this is the bulge which you can see, and the capsular bulge which you can see, which I pointed out on the previous film. Brody's abscess per se is can be at other locations. It is usually metaphyseal, but please remember it can extend to the epiphysis. So it can be subarticular also. And uh, candidate
Thank you
one,
very
thank
much,
you very
Shafika.
much. Okay, candidate
Yes,
two,
sir.
are you with us? Okay, so madam, this is penumbra sign. Just describe the findings. What is the penumbra sign? Where do you look at? Which
At T1, I would find a high signal intensity RAM of a low intensity.
which one of these are T1?
Sorry, the one at the far left of the screen or the right side of,
Excellent.
yes, this
Yeah, this one.
without fat sat. And then the middle one is a steer or a fluid sensitive sequence. I think both are fluid sensitive sequences, the coronal and
Yeah,
septal, the other two.
excellent. So, what is the penumbra sign? Describe it for the audience.
So it is a RAM of high signal intensity on T1 weighted image of a low signal intensity lesion, which would have a fluid signal when compared with other sequences of the lesion. And it would be characteristic of Brody's abscess.
Excellent. So, main point to remember is that on a T1 weighted sequence, a Brody's abscess or intra osseous abscess has got high signal rim on a T1 weighted sequence. This is the key point to remember, and you can call it a Brody's abscess. This one again is metaphyseal, but it is also extending to the epiphysis. So this patient is a prisoner. He ended up in the prison because he had a fight uh, and on a Saturday night, fist fight, and then he developed some symptoms. Over to you. What are the findings here? What is your diagnosis?
Presented with a zoomed in radiograph of metacarbophalangeal joint, I assume. There is a subtle lucency with involving the metacarbal head. I'm not sure. I think it is the ulnar aspect at the left side of the image.
Yeah, fifth.
Okay. Okay, at the ulnar aspect of the image with surrounding subtle sclerosis. There is also narrowing of the joint space and sclerosis at the other side of the joint. So I'm concerned about infective process. So it might be osteomyelitis.
What is happening to the joint space?
There is narrowing of the joint
Okay,
space.
so this is,
Compared
yeah, that's fine. So this is fifth metacarpophalangeal joint. You did well. Basically, point to remember is that this is what we call indirectly a human bite, fist fight. So no, jaw of the other is what will cause this. And the rate of infection is quite high in this kind of scenario. Basically what is happening is that if you see here, there is loss of definition of the head of the, look at this, and loss of, one can argue that there might be subtle erosion here. With that, there is loss of joint space. Key finding in osteomyelitis is loss of joint space. So in a PEDS group, initially the joint space can enlarge. Why? Because of fusion. But once there is cartilaginous damage, then it will reduce. And then there is a soft tissue component. So this is septic arthropatophalangeal joint. So here uh, we will skip this. The key point for the exam is this one: ultrasound. Highly sensitive. Ultrasound is the diagnostic method of choice for hip fusion, also guides aspiration, and they will ask this again and again. So we consider it a medical emergency. Remember that. MR is very sensitive, 100% sensitive, specific is 77. And the key point is that low signal on T1, flutes on fluid sensitive, it will be high signal. On a post contrast, what will happen? There can be two things. One is inflammatory phlegmon. Inflammatory phlegmon will enhance, and if there is an abscess, then there will be surrounding. So abscess will be infected fluid, or it will be necrosed fluid with marginal enhancement. Yes, please. 37-year-old male, left-sided symptoms. Over to you.
Yeah, I'm presented with AP pelvis radiograph of a skeletally mature patient. There is narrowing of left hip joint with lucency of the acetabular roof, I think. And there is also subtle lucency of the involving the femoral head with admixed with sclerosis. There is also distension of the fatty planes, particularly the iliopsoas and the capsular. Also, I think the obturator is also distended. So my first differential diagnosis would be septic arthritis. I would do ultrasound to confirm my findings.
Adult. You can do
Um,
ultrasound, but better is what?
so to do MRI?
Yeah. So in children, the point is that ultrasound uh, confirm it and aggressively treat it. This is quite a full-blown case. Here, what is happening is, distension of the fat planes will be difficult in adults to see. But what is happening is that there is soft tissue, obliteration of the fat plane, and there is increased density, which is, here there is fatty, and here there is a bit of soft tissue. Key finding is that the joint space is reduced. Joint space is reduced. And then look carefully. And key finding is the acetabulum. And look at this acetabulum. It is crisp and sharp. Look at this articular surface. Here, that is gone. And you look carefully, and there is this bony destruction. There is a lytic lesion, actually, which is on the acetabular component. So this is, acute osteomyelitis, septic arthritis, should I say. And this, appeared ultimately proved to be TB, but nobody is asking you, or nobody can diagnose that this is TB. Just say that this is infection, septic arthritis. Next case. This patient is 80, female, dementia, fever, bed sores. Over to you.
I'm presented with a pelvis radiograph of an old age female patient. I can see that there is destruction of the femoral head with dislocation, and also there is air, multiple air locules projecting over the proximal end of the right femur. So I am concerned about septic arthritis caused by gas-forming organism, maybe
And
caused
um,
destruction.
what is happening to the surrounding bones?
So there is osteolysis of multiple bones, particularly the pubic rami bilaterally.
Right. So in this particular case, we can see that there is bony destruction. This ischium. There is, the acetabulum is completely destroyed if you compare it with this acetabulum. And where is the head of femur? That is gone, actually. It's all eaten up. And so even the neck is eaten up. The key finding is this lucency, which was well picked up by the candidate. This lucency means air. Where is this air? This air is within the joint space. and it is causing this destruction. So this has to be septic arthritis. Now, on this MRI scan, we can see this is a T1, this is a stir, this is post contrast. And we can see the same findings. The air, of course, low signal on this post contrast as well as pre. On post contrast, we can see this enhancing phlegmon. And here, of course, there is no fluid, there is air which is in surrounding uh, high signal or enhancement. But the key finding in this case was that there was air here and there should not have been any air here. Well done. Okay, this is the case for which I showed the MR to candidate 1 initially, and I'll again show you the MR, but can you describe your findings here?
Yes.
It's a classic, very good to be case.
So lateral and frontal radiograph of the left forearm and wrist joint of a skeletally immature patient. There is an ill-defined oval-shaped lucency seen at distal diaphysis of the left radius bone with surrounding sclerosis. There is also some surrounding soft tissue distension seen on the lateral view. So appearances are those of aggressive lesion. My differential diagnosis would include infection, maybe Langerhans cell histiocytosis, or even Ewing's sarcoma, considering
So
patient's
why
young
did you
age.
say aggressive?
Well, it has a wide zone of
Right,
transition,
right.
and
Excellent. Okay. So the point when you see a case in the exam in the bones, this is a big term. Now, if you see here, of course, I think next to next session is tumors, where we will consider all of this in great detail. When you see a tumor, what are the 10 things which you look at? Age, location, zone of transition, margin of the lesion, tumor matrix, pattern of bony destruction, periosteal reaction, cortical response, soft tissue involvement, size of the monostotic or polyostotic. In which, in this, other than age and location of the lesion, the key thing is zone of transition. Always, 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 it should be in part of your description. This is just like in brain. If you see a tumor in the brain, is it intraaxial or extraaxial? And the differential diagnosis totally changes. So, zone of transition similarly is a key word which you must remind yourself that I am describing a lesion in the bone. I have to tell in my report and to tell the examiner what is the zone of transition. And that will really help you. Zone of transition by definition means transition from abnormal to normal bone. Narrow zone of transition means benign lesions. And this is an example of a narrow zone of transition where you can see crisp and sharp outline, normal bone, abnormal bone. But in our case, look at the zone of transition. There is something abnormal here, but all of this looks abnormal. All of this looks abnormal. So you're not very sure where is the normal and where it becomes abnormal. And the candidate did very well. Please remember that when you see a wide zone of transition, you cannot do not use this word that this is malignancy. Use the word this is an aggressive lesion. And between the line, what are you telling the examiner? Aggressive lesion can be infection, aggressive lesion can be a tumor. Again, the candidate did well because in this age group, what are the aggressive lesions which can cause this type of finding? Uh, Ewing's is the key, top, and then of course LCH, you can definitely keep it in the differential. One thing I want to add is that there was a bit of periosteal reaction on the lateral. So this is the case which we did see in when I was showing you MR of MSK. And here, this is a T1 T1 weighted sequence. This is a stir sequence. This is a T1 fat saturation sequence. This is that you can see here also Brodie's abscess. A lot of edema which is low on T1, high on abscess. Now on an axial sequence, you can see that there is a a sort of a cloaca which which is communicating with the surrounding soft tissue phlegmon, which is enhancing. You can see this enhancement and look at this hole here, the breach in the cortex. Yes, please. Madam, are you with me? Maybe you are muted. Let me check.
I'm sorry. I was
Yeah.
mute.
Yeah.
I'm presented with leg radiographs of a skeletally immature patient. There is ill-defined lucency seen at proximal shaft of left tibia with surrounding cortical thickening and sclerosis. Um, there is also periosteal reaction seen on the AP radiograph, I think medially. And I can't see any soft tissue extension, but maybe there is some soft tissue edema, surrounding soft tissue edema. So again, appearances are those of an aggressive process, considering the wide zone of transition of the changes. And my differential diagnosis would include infection, Ewing sarcoma, and maybe Langerhans cell histiocytosis. I don't think the lesion is intracortical, so I'm keeping osteoid osteoma out of the differential.
CT and MR for you.
Okay, on CT scan, I can see a central lucent lesion with surrounding bony sclerosis and a defect coursing cranially, so in keeping with cloaca. And there is on the MRI, I can see that there is ill-defined hypodense lesion with so we have a T1. We have a hypodense lesion with a hypointense REM on T1 weighted image and corresponding hyperintense signal on fluid sensitive sequences. These are both steer on the axial. There is also a sinus tract communicating to the surrounding phlegmon. So appearances are those again of chronic osteomyelitis.
Okay, fine. Thank you. So actually, the problem is that this is not projecting very well for you on this PowerPoint. Otherwise, if you look carefully, just look what is happening. You can see there is some lucency here. And again, it is not projecting for you, but I want to highlight that you can see a linear lucency here. Linear lucency, actually, you can see here also. And this is what we call cortical tunneling. Tunneling is the word, tunnel. And tunnel is very specific for osteomyelitis. Now, it is chronic osteomyelitis. Now, look what happens. That look at there is end osteal, new bone formation here, and that is why look at the medullary cavity. It is all encroached, and similar findings here, where you can see this, this tunneling. It is breaching the cortex. It is going in the medullary cavity, and of course the same finding on MR. And then you can see this cortical breach, and you did very well, where there is a sinus tract and perifocal abscess. Well done. Another case of osteomyelitis. But my main idea was to show you cortical tunneling, which is not visible to you because of the projection or the quality of the X-ray. Well done, candidate 2. Can we take candidate 3 now?
Thank you.
Yes, sir.
Candidate 3 is a co-host. Yes, are you with me, candidate
Yes.
3?
Yes.
Okay. Describe this lesion in this rib. Over to you.
Provided lateral projection view of the frontal and lateral projection view of the right one side of the chest, showing a ill-defined lytic lesion involving the anterior.
Slightly, your volume is slightly. Can you please speak up?
Sure, sir. Am I
You,
audible now, sir?
yeah, better.
Yeah. Ill-defined lytic lesion involving the anterior aspect of the rib. Uh, Sixth rib on the right side, or yeah, on the right side, with a small area of sclerosis in the central aspect, wide zone of transition. Uh, I, I can see some surrounding soft tissue as well. So yeah, this is with wide zone of transition, some periosteal reaction. I would think of an aggressive bone lesion in infection, and it's look like a, yeah, it's a 15-year-old child, so I would keep the differential less likely. Um,
I'm waiting
differential.
for the other differential you wanted to say.
Sir,
Other than infection, what is the difference?
encontrauma, but unlikely with this aggressive feature, and yeah, that's all I can. Langerhans
Enchondroma. Okay, and what else?
Langerhans histiocytosis,
Okay, what else?
LCH,
What else?
Ewing's, but it's unlikely.
And why do you say but for events?
Sir, first of all, it's a flat bone, usually seen in the long bones in the diaphyseal location, and the reason is the soft tissue component is less.
Okay, thank you. So, you see, this is a case in which what we see, first of all, the findings and then the differential diagnosis. So, there is a rib here in which there is destruction. Now, all of this rib is destroyed here, this lucency. There is periosteal reaction where I'm pointing out. So, there is a very aggressive lesion. Now, once you pick that up, then the differential diagnosis is what we are talking about. Now, the differential diagnosis, just on a CT, you can again see there is bony destruction and some soft tissue component. Now, the differential diagnosis, focal rib lesion, solitary or multiple. Please remember that the examiner wants the differential diagnosis in this case, right? In this case. So you did confine yourself to a young age group, 15 in your differential, but enchondroma, this is not at all enchondroma. Enchondroma is not an aggressive appearance. It will not cause this destruction, etc. Ewings, by the way, Ewings in flat bones is more common. What I mean is that you apparently have got this concept that it is more common in long bones and not in flat bones. No, or axial skeleton. No, that is not true. Any bone, particularly in this age group, infection and Ewings, blindly you should talk about them together. And of course, on a plain film, you cannot commit how much is the soft tissue component. So aggressive lesions, infection and Ewings, they go together. Please also remember, even clinically, they go together because both of these lesions, infection and Ewings, can cause, Ewings can present with infection-like symptoms, actually. Raised ESR, fever, etc., etc. So in this particular case, the differential diagnosis is the key thing. And for that, the key thing in this age group is, so this is in a child, right? It was 15 years old. So the key thing is osteomyelitis. And other than that, LCH. And other than that, Ewing sarcoma. If you want to keep metastasis, okay, I'll accept that. but you cannot and cannot consider enchondroma in the differential diagnosis.
Yes.
Okay, candidate, this is candidate three. So aggressive or non-aggressive lesion, what do you think?
Aggressive lesions.
Describe it for me, please.
Ill-defined lytic lesion involving the mid shaft of the fibula with a wide zone of transition and adjacent interrupted periosteal reaction in the lateral aspect. Uh, and also in the medial aspect, I can see solid periosteal reaction as well. Sorry, the solid periosteal reaction in the lateral aspect, and some soft tissue extension into the medial interosseous portion. Other than that, I can see a small lytic area in the proximal shaft of the fibula as well. So it's possibly cortical
Proximal
tunneling.
shaft of what? Say again.
Proximal shaft of fib. Uh,
Of fibula.
so it's ulna. Sorry.
Uh, right.
Yeah. Possibly cortical tunneling. Not sure. Yeah.
So the main point is that this is an aggressive lesion. It is not lytic. It is destructive. You don't see a lucency. I'm just debating that term, lytic lesion, you said. So
Okay, sir.
don't think that all aggressive lesions you will see a lucency there. Don't think that. That is why I'm elaborating on this. It is causing a lot of, if you look in detail, this cortex is destroyed. This cortex is destroyed. There is a periosteal reaction, and then other than that, uh, soft tissue component, you did well. If there might be something. Now, the differential diagnosis is what we are talking about. Aggressive lesion here, mid shaft. So
Wings are
this can be, what will you consider?
wings and infection osteomyelitis.
48 years old. Here comes the catch,
Okay.
right?
Metastasis. Yes.
So you see, in last case, you did very well, where you confined yourself to the age group of the patient. That was a 15-year-old, and you did well to give me a differential diagnosis, which was in that age group. But one thing we debated, that enchondroma should not have been talked about. In this case, the differential diagnosis, you should not consider events.
Sorry, sir. I didn't notice the age. I'm sorry.
Yeah,
Yeah.
so, okay, you did not read the age. Yeah, so so the key point which I am making here is, I have shown you so many times, and even today I projected that, but I did not talk about that in the examination, the the examiner wants you to tell them the differential in this case, which you are seeing, this age, this site, this radiological feature, this clinical features. What is the differential? So I take your point, because today I'm showing you PowerPoints. Maybe you did not read the age. So that's fine. So in this particular case, Ewing should not be there. There are other tumors which can happen. This is a sweeping, differential from your book. There are other tumors which can happen here. And by the way, there osteosarcomas even happen. Diaphyseal osteosarcomas can
Yes.
happen.
Yes.
But so that is what this this case was. Okay, 48-year-old, uh, of course, has got pain, swelling, fever. Over to you.
Provided lateral projection of knee joint in a 70 and lateral and frontal projection knee joint. 78-year-old female patient present with pain, swelling, and fever. I can see the post hip replacement processes. There is ill-defined lytic area involved, permeative lytic lesion involving the proximal tibia. Uh,
Proximal tibia here.
yes, sir.
So don't worry, this is all, a bit of osteopenia, etc. Don't worry about the tibia.
Okay. So other than that, I can see lytic areas involving the patella. uh,
Sorry, say again. Which part?
patella.
Patella. Okay, so this is also osteopenia. Don't worry about this. What else?
Then I can see an interrupted periosteal reaction involving the medial portion of the femur with ill-defined lytic lesion in the distal femur, the corresponding to the anterior cortex of the femur.
You're talking about this area where I'm pointing out?
Yes, sir. Yes, sir.
So this is also projectional. This is similar to this. This is quite a bit of osteopenia.
Okay. Other than that, I can see a obliteration of the soft tissue planes of the distal surrounding the distal femur with mm,
So this patient has got a total knee replacement, right?
replacement. Yes, sir.
So now the question is, with this kind of swelling, what is happening? This kind of symptoms, I mean to say,
Possible and infective etiology, septic.
and on which radiological finding have you reached that conclusion?
The soft tissue obliteration of the
Soft tissue
distal
obliteration of
of
the
the fat planes.
which fat
In
planes
the
are we talking about? You're talking about suprapatellar fat plane and things like that. You see, fusion can cause this. Key finding in this case is this lucency.
okay.
You see this lucency. This is a classical
Yes.
exam film. This can come in your rapid reporting also, that kind of a case where uh, the between the prosthesis and the parent bone, you should not have this lucency. This means a bit of loosening. And with that loosening and with this, you pointed out there's a bit of effusion here. You call it that this is, infection. So that is the key finding, this lucency. Yes, please.
So provided frontal projection and lateral projection of a cervical spine, cervical spine of a 72-year-old male patient with neck pain. Striking abnormality I can see is C5, C6 area. There is a reduced intervertebral disc height and collapse of the partial collapse of the C5 vertebra and mild lateralostosis with the widening of the prevertebral soft tissue at this C5, C6 location and also extending up to the C4 to C7 levels. So possibly, and yeah, spondylodiscitis with a prevertebral abscess. So I would inform this finding to the referring clinician, check with inflammatory markers, and also suggest further evaluation the MRI, contrast enhanced MRI cervical spine.
Excellent. Well done. So in this particular case, what is happening is that there is a collapse here. You can imagine that there was an intervertebral disc in between, which is gone, which is all eaten up. The end plate, vertebral end plate, inferior and superior, partly eaten up. There is a bit of localized kyphosis. And so when the disk space is gone, which is eaten up, it is taken as a sign of infection. Remember that. With that, I was looking for this finding to be pointed out, which the candidate did well. This soft tissue anterior to the spine has got various measurements, and in this, distal to C5, it is about 2 centimeter. But another formula to remember is that distal to C5, the if it should not be more than the AP dimension of the vertebral body. There is a definite soft tissue abscess. So this case was TB, but I'm not expecting you to call it a TB. Just call it infection. That is fine. And the key finding is that the intervertebral disc is also destroyed. This is the differential in your book, multiple collapse vertebra. Of course, our case was a single collapse vertebra. Yes, please.
Yes. Provided frontal and lateral projection of wrist with proximal hand showing uh, an ill-defined lytic lesion involving the distal uh, radius, the epiphy distal radius with the wide zone of transition, and a thin rim of sclerotic margin. And also there is associated cortical break in the uh, lateral along the lateral cortex. No matrix mineralization, no soft tissue component. So it's aggressive bone lesion causing possible pathological fracture, and there is reduced joint space of the radiocarpal joints, and the radioulnar joint and the rest of the carpal bone shows normal, no similar lesions are noted. So there is an interrupted periosteal reaction which is well appreciated on the lateral projection. So aggressive bone lesion with a 45-year-old female patient, I would think of again infection, one possibility. Other possibility will be a metastatic lesion. I would inform this finding to the referral clinician, discuss the case in the orthopedic and
Anything else in your differential?
sir. A giant cell tumor is not at this location. Usually, it's a particular. Usually, extend up to the lateral position.
Uh, you said it is not in this location. What does that mean? What do you
Sir,
mean?
it's usually extend up to the lateral subarticular location.
You mean to say it is eccentric?
Eccentric, yes, sir.
Your lesion is not an eccentric. If you see here, this is the lesion.
Yes, sir.
Here it goes till the end. Here it is not going till the end. It is slightly eccentric.
Okay. Okay.
So, can it be a giant cell tumor?
Yes, sir. But usually it's not that it's locally aggressive, but
Right.
not. Yeah, it's locally aggressive, but not with the
Anything
wide
else?
zone of transition.
Anything
With
else?
wide zone of transition, it's not possible.
Uh, Anything else in the differential?
Without any matrix, I can't think of anything else.
So there can be no other differential?
It can, sir.
Sorry, asked you that any other differential, and you're saying that there might be something else also? What do you mean?
Multiple myeloma.
Multiple myeloma. 45. Good, well done, well done. You see, I was a bit harsh with you, but that was intentional. And this is what I call grilling in the exam. And this is classical. The same thing will happen in the exam. 100% same thing will happen. And you did well, but you lost a bit of confidence. So you should have stayed firm. Let me tackle it. First of all, if you see, you described it very well. There is a lesion which, you know, slightly wide zone of transition here, and then where were we? There is a bit of periosteal reaction. You did well. You commented that I feel that this joint space radiocarpal is also reduced. So perfect here. It was absolutely perfect. Then you said differential diagnosis, infection. And by the way, this is what it is. Of course, non-TB infection can also be kept in the in the differential. Nobody is expecting that you will call it a TB. Now uh, comes the differential. In the differential, initially you were looking for aggressive lesions in the distal radius in a 45-year-old male. You said metastasis. Fine, I'll take it for the simple reason that it is rare, but it can happen. Absolutely, I'll take it. And then giant cell tumor. We started debating the giant cell tumor. So giant cell tumor, you were not convinced that this is giant cell tumor, and part of your reasons were right, uh, but you lost your confidence. And that is the feedback from my side. You should not have lost the confidence. It is,
Yes.
and this is classical. Good that it has happened with you here, and good that people are listening. That anybody will tackle it like this. And in the exam, it can be very, sometimes it's a total benign lesion, and the final thing will be Can it be malignant? Yeah, the examiner will ask you, can it be malignant? And you have to stay firm. So otherwise, you did it very well. Well done.
Thank you so much.
Now, uh, so multiple myeloma, by the way, you could not say in a 45-year-old, don't say that. Now, this is lucent epiphyseal bone lesion, and there are lesions which are related to the joint. Giant cell tumor is there, which is non-sclerotic margin, extends to the metaphysis, mainly chondroblastoma is in young age group. Infection, of course, we have to keep that. Local specific lesions, this is in talus calcaneum, we chondrosarcoma, no. And then comes these lesions, which can occur anywhere. For example, metastasis, you did well, where you mentioned that. Myeloma, we cannot keep in this age group. So it is a very, very good case for developing your concept of how will you deal with a differential diagnosis in the exam. In this case, what is your differential? So, and to stay firm. And many times I use the word grilling, and you will be very disturbed. Oh, I have done so well, and the examiner is still grilling me. This is what they do at times. They keep going on and on and on, and try to check your confidence. So stay firm there. Otherwise, you did well. Well done.
Thank you so much.
Spot diagnosis, what is this?
So tuberculosis spondylodiscitis, bilateral calcified psoas abscess.
Excellent. So this is a case of chronic uh, bilateral psoas abscess with calcifications, which can happen in historic TB. And if you see this gibbous deformity, uh, uh, the disk space is completely gone, and these. So this is old case of TB. Why I'm showing you is that what can happen is that they might show you if examiner has got this film and has something else going on, then you should have an idea that TB with calcification, old TB can present like this on a plain film. So, candidate three, you have done very well. Well done. And
Thank you.
let's take a 5 minute break. Today's session is 3 hours. It will go till 9:30. So take 5 minutes break, and I am stop sharing. My co-host, if you can project that poll once again, the pre-session poll once again. And for the 22nd session, can anybody project that? Project your slide, I mean to say. Co-host? Yes, and excellent. So we'll take a 5 minutes break, and please, uh, those of you who have not uh, fill up filled up this poll, going to make you a co-host. Candidate 3, thank you very much. Well done. So, candidate 4, are you with us?
Yes, sir, I am here.
Okay, so let me. Okay, candidate 4, uh, just concentrate on these sequences. I have given you actually what it is and describe the findings to me.
So I've been provided with the MRI sequences. I can see there's altered area of marrow signal, which is appearing hypointense on T1, hyperintense on T2 and stir, which is involving the adjacent end plates, that is the inferior end plate of L5 and superior end plate of S1. And there's reduced joint space, and the joint space also appears irregular. And there's even the joints intervertebral disc space also appears hyperintense on stir and T2. And on post contrast sequence I could see that there is enhancement of the intervertebral disc space as well as the superior and the inferior adjoining vertebra, and there's some prevertebral collection as well. So in according to these findings, I'm thinking in terms of discitis. This could be a pyogenic discitis, and which could that is bacterial, which is involving the disc and the adjacent vertebra with the prevertebral collection, and there's no extension into the spinal canal. And as I'll inform these findings to the referring clinician.
Okay, well done, well done. So if you see here on a T2 weighted sequence, first of all, look at the intervertebral disc and you can see a bit of fluid inside, which of course is not the, the nucleus pulposus, it's different. When you see a fluid on T2 weighted sequence, that is very worrying. Then look at the stir. On the stir, the fluid becomes more obvious, and then you see that there is edema in the adjacent both of these vertebral bodies. And if you see the end plates are irregular; they are partly destroyed. And so if you just go for our formula of marrow signal, we can see that on T1 weighted sequence, the marrow is lower than the intervertebral disc. And of course, whatever is low is high on the stir. On post contrast, everything is enhancing. So please remember that when it is enhancing means there is no liquid component and it is still what we call a phlegmo. And bone marrow edema will also show you enhancement. The candidate did very well. We are ruled out anything happening within the thecal sac. So this is, use the word spondylodiscitis, elaborating that there is disc as well as adjacent bone is involved. Well done. Another case of spondylodiscitis. Here, what is happening is, let me describe the findings, then I will ask you a question. So if you see here, this is a T2, this is a stir, this is a T1, and this is a post-contrast T1. In this case, we have not done a fat-saturated pre and post, and that should have been done. But I just want you to ask a question to you. So on this T2, we can see that on this stir, we can see that there is high signal here, and look at the edema. Edema is high signal on stir. On T1, that is low signal. So till now, everything is quite obvious. Now this is pre and this is post. What is happening here? Over to you, Candy.
So on the post-contrast T1 T1 sequence, I could see that there is a epidural collection which was appearing hypointense on the which is enhancing. And so in this is a case of a spondylodiscitis with a epidural abscess formation.
Right. Will abscess enhance in toto?
That will show a peripheral enhancement. So in this case, it could be a phlegmon.
Exactly. So this is what it was about, this case, this finding. And this finding is extremely important finding. It is extremely important in head and neck also. By the way, it is extremely important in the liver also. But let me give you the context. But when there is an infection, there is liquefaction. When liquefaction happens, then there will be a liquid component, and the margin will enhance. That is drainable. Before that, it will not be liquid. So you put in a needle, there will be nothing to drain. In a liver abscess, this happens every day, and you might have seen cases where you're worried about infection, and you will tell the clinician. They will say, "Can you drain it for me?" And you will say, "We'll wait another 24 hours or 48 hours, and we will rescan. And when there is a liquid component, then we will drain it." So that concept holds very, very important concept in the spine, very important concept in head and neck also. Subperiosteal abscess of orbit, etc., etc. So you should have a clear-cut concept that just remember it like that infective, inflammation which is enhancing is phlegmon. When there is a liquid component, which is the abscess, then there will be ring enhancement and the necrosed part will not enhance. So this is because they will ask you, what should we do? Should we go in? Should we drain it? Blah, blah. So you will tell them, no, it is not drainable. Okay, now Aunt Minnie case. What is a Aunt Minnie case? Aunt Minnie case is where there is no differential diagnosis. In 2B exam, trend of Aunt Minnies is less and less because the examiners know that candidates have mastered Aunt Minnies. So Aunt Minnie by definition is a case in which there is no differential diagnosis. But this is an Aunt Minnie case. What is the diagnosis? Can you describe and give me the diagnosis? Still you should know that what it is. And I always say that in head and neck, for example, for a radiologist who does a lot of head and neck reporting, for you a case will be Aunt Minnie, but in the 2B world, still they will ask you because they know that your exposure to a head and neck case is not all that much. So over to you, candidate. What is this?
So I could see that the first metacarpal appears, especially the diaphysis portion, it appears expanded and is replaced by a expensile lytic lesion, which has narrow zone of transition. And there's no associated periosteal reaction, no cortical break, but there's associated soft tissue swelling. And I'm thinking this is a case of an infection. This could be TB dactylitis. I could see some a lace-like pattern within. My second differential would be in chondroma.
Hmm. So, lucency, did you see a lucency in this case? This is basically, you are absolutely right. This is what we call uh, spina ventosa or TB dactylitis. Spina ventosa or TB dactylitis. Historically speaking, the word spina ventosa is a German word, means a short bone which is inflated with air, inflated with air. Interestingly, historically speaking, this is the first diagnosis, abnormal diagnosis, which was made on an X-ray, by the way, in a child. X-ray of a child was spina ventosa. Now, so basically, what is happening? This is a particular type of TB uh, in which there is expansion of the medullary cavity. Remember this word, expansion of the medullary cavity. It is a balloon. It becomes inflated like a balloon. It can be phalanx. It can be, the metacarpal or the metatarsals in also. And second thing is that uh, there is expansion. So this is another example. This is another example of this spina ventosa. By the way, syphilis dactylitis is a differential, though I did say that this is an Aunt Minnie because of the expansion of the medullary cavity. Enchondroma will be a lucent lytic. This is not a lucent lytic lesion. And that will be a lytic lesion, and that's different. Second thing is that in syphilitic dactylitis, there can be thickening of the phalanx or the metacarpal, but that is because of cortical thickening, periosteal reaction. So expansion of the medullary cavity, just remember that. So that is it. By the way, you did use the word lace-like. So let me show you a case here. Over to you.
So I've been provided with X-ray foot, AP and oblique view. I could see there's involvement of the distal phalanx of the first toe and the proximal phalanx of the second toe, which appears abnormal. There's appearance of abnormal lace-like pattern involving these phalanges. The adjoining joint spaces appears normal, and rest of the bones also appear normal. So and there's no associated soft tissue swelling or no periosteal reaction, no cortical destruction. So this lace-like pattern is seen in sarcoidosis. So my first differential will be sarcoidosis.
Anything else?
Um, Second, I'll keep as TB dactylite. No, so sarcoidosis.
Anything else?
No,
TB,
sir.
ruled out.
And uh, so there's soft tissue swelling of the first toe, and there's a bony erosion. So less likely gout, but this is not the position, so no other differential.
Okay, very good. Well done. But so first of all, let's go back to your original case. You know, this is not lace-like. You use the word lace-like. This is lace-like. So basically, in sarcoidosis, what happens is there are punched out lesions giving you that this lace-like pattern. It can be hands, it can be feet, small bones. Now you did very well as far as differential diagnosis, but how can so I was again grilling you, the word which I use, grilling you. Anything else, and uh, so there are two or three ways to deal with this kind of scenario. You actually dealt with it, but you could have been more emphatic. So uh, deal with it, you know, uh, just like you did, where you said that I can consider gout. However, because of this factor and that factor, I can rule that out. Overall, this is pathognomic. You know, this word should be in your vocabulary, pathognomic or classical. This word can be in your vocabulary. Now, uh, that this is so the thought process, you are giving your thought process to the examiner, you are showing your thought process and then staying firm. So you did very, very well, but just a bit of a minor point. Regarding soft tissue swelling, uh, can there be soft tissue swelling in gout?
Yes, sir.
Correction, in sarcoidosis. Correction.
Um, sir, don't know, sir.
Don't. Okay. Okay. So, lytic lesions in the phalanges and well defined, and these well defined include sarcoidosis and all of these things. Fine. Now, if you see, this is the answer to your question, to my question. Look at this soft tissue here. Look at this soft tissue. This is another case, and this is, of course, from StatDX. Inflammatory disorder of unknown cause resulting in non-caseating granulomatous deposits in tissues, including bone. So soft tissue swelling is very, very common. It can happen. Soft tissue nodule. Just remember that. So don't get confused if you find it. Now, just to highlight, I'm not going to go through it. Sarcoidosis is one of the favorites in the exam, and you for long cases, things like that. I have shown you cases in previous sessions regarding neurosarcoid, and I have told you that it is the greatest mimicker. So you can get long cases of anything from here and here, or here, or from here to here. So you have to have a clear cut idea. The second part of Chapman, uh, there are things which are multi-system, and you should have a clear-cut idea. Remember my words. One line there will save the day for you in the exam. If you know that this is what there is, I cannot. It is very well written by Hamid, the editor, and one line in this list will simply save the day for you in your exam. So always, revise it from there. It's very consolidated. Everything what requires for the exam, what is required, is given there. Sarcoidosis, TB, you name it. Everything is there. So virtually pathognomic in the setting of clinical sarcoidosis, lacy lytic bone lesion. Virtually pathognomic. So this word should be in your vocabulary when you want to be very emphatic. Sir, this is pathognomic for sarcoidosis, or it is classical for sarcoidosis. Stay firm there. And so clinical associated with pulmonary lesions in 90% of cases. So they might show you some X-ray and a plain film as a long case. And so Small bone sarcoidosis we associate with skin lesions. So remember that soft tissue component can be there. Another case of sarcoidosis, and this one is multiple lesions in the bones uh, in the hands. Yes, please.
So I've been provided with X-ray lower limbs of a skeletally immature child. I can see there's eccentric lytic lesion which is involving the medial metaphyseal corner of the bilateral tibia, upper tibia, and there's apart from that, I could see a smooth periosteal reaction, which is bilateral symmetrical, which could be physiological in this case, this age. And however, I cannot appreciate there's no joint swelling. Um, so in my differential would be Blount disease, and second, there are no Wimberger ring sign and any other findings, so it is not scurvy. And um, so third, I'll keep as infection. Um,
Which infection?
so could be a septic arthritis um, because of these lytic lesion. However, I cannot see any appreciable joint effusion, and uh, so this scurvy. So because of this epiphysis has that Wimberger ring sign. I'll keep my differentials of scurvy as well, and these periosteal reaction might represent subperiosteal hematoma, and this medial pointing of the distal femoral metaphysis. This could represent Pelkin spur, and there's relative lucency just at the metaphysis, which could represent the Traumerfeld zone. So yes, these findings are representing features of scurvy.
So what is Wimberger sign?
So Wimberger ring sign is when the epiphysis, it shows a sclerotic rim around, um, which is known as a Wimberger ring sign.
Okay, so I'll take over. You know, this is my favorite differential diagnosis in Chapman, and I do teach it in great detail. I can teach you 3 hours on this differential diagnosis, and uh, it is a very important differential diagnosis. And as a monologue, I'm going to go into a teaching mode. I will like to cover it within, let's say, 5 to 10 minutes. It's a long subject. And in your, if you see FRCR exam, FRCR is a jigsaw puzzle of so many things. And one of those is differential diagnosis. And second one is your theoretical knowledge of things. So you should have theoretical knowledge. You apply your theoretical knowledge, and the in the other side of the brain, you know, the right hemisphere has got a differential diagnosis, and in the left hemisphere of the brain is the theoretical knowledge. And as you are speaking, because the differential diagnosis is you are trying to evaluate or tell the examiner what it is. And many a times you can get a single conclusion. Remember my word, single. And it will be absolutely pathognomonic. There is nothing else. And if the examiner grills you, you can again, hold your fort and just stay firm and tell your thought process and still do not change your differential. Now, first of all, let's go through a bit of the differential diagnosis and a bit of theory behind it. So look at these words. Normal infants, juvenile, what is the differential? Periosteal reaction, bilateral symmetrical in children. Normal infants, juvenile idiopathic arthritis, acute leukemia, rickets, scabies, scurvy, prostaglandins E, and congenital syphilis. Now, please remember one of the key factors is age. Age. So, age of the patient is the key thing. And in this particular case, candidate, what was the age of the patient?
So I forgot.
This is the patient. What is the age of the patient?
Uh, so it's less than 6 months. I couldn't see the femoral head.
Excellent. Now, uh, out of, if you just consider age, JIA, does it happen in this age group? Question.
No, sir. No, sir.
Acute leukemia,
No, sir.
rickets,
No, sir.
Caffeys.
Caffey's disease can happen, sir, but it won't
Okay,
be bilateral.
less than 5 minutes, huh? And 5 months. Scurvy,
No, sir. More than 6 months.
more than 6 months. PGI therapy. And what is this? Congenital?
Syphilis.
Can it happen?
Yes, sir.
Okay. Normal infants, can it happen? Physiological.
Yes, sir.
But you see, one thing you have to consider is age. Second thing is the radiological features. So let's go back. Now, you did initially tell me that it is normal physiological periosteal reaction. Now, this normal physiological periosteal, diaphyseal, no single growth plate, bilateral smear, single laminar, fibula, femur tibia, humerus, very unusual, more than 4 months, mimic trauma. You know, this is what is written there. We'll come back to this. There is another differential diagnosis, which is radiolucent band, which can be metaphyseal band, and congenital infection is one of them. This case is a case of congenital syphilis, and it's a pathognomic finding. Pathognomic is the word. It's classical. There can be no differential diagnosis, and I can, why can there be no differential diagnosis? Now, if you see here, there is bilateral erosions of the upper tibial metaphysis. Bilateral erosions are pathognomic for congenital syphilis. Interestingly, this sign is also known as Wimberger sign. And by the way, in scurvy, there is a sign, the pencil thin cortex of the epiphysis, that is also known as Wimberger sign. But in scurvy, you will not see this erosion. With that, there is a lot of periosteal reaction. This is very exuberant. You will not see a single lamina. And usually in classically, in physiological, it doesn't happen like this. And you can see erosion here. If you stretch your imagination, maybe a bit of lucency in the metaphysis. And you remember there is a differential diagnosis here. Solitary radiolucent metaphyseal band and congenital infections is one of them. Now, you did very well regarding the age of the patient. Now, age of the patient is judged by the head of the epiphysis of the head of the femora. So the head of the femora in girls, it can appear anywhere between 3 to 6 months. In males, 4 to 7 months. And we don't see that. You are absolutely right. So the age is definitely less than 7 months. Scurvy, by the way, can happen in after 6 months, because till 6 months, the ascorbic acid goes from the maternal blood to the fetus or the baby, should I say? You see this? People think that congenital syphilis you will not see in UK. No, you will see it in UK. This is 2017, by the way, quite old, but it says 5920 cases of bacterial infection, up 12% from 2010. And this is from your book. Syphilis is divided into tertiary syphilis and congenital syphilis. So I'm not reading from here, but I just want to highlight this, that congenital syphilis, this is same page, a bit of a blow up. Early onset 0 to 2 years. Uh, which bones are most commonly involved? Tibia, femur, humerus. Periosteal reaction, common find bilateral symmetrical. Metaphysis, lucent band and irregularity distal. Focal destruction of medial. Look at this. Focal destruction of medial proximal tibial metaphysis bilateral is pathognomic of Wimberger's sign. Pathognomic. End of story. This is what I tell you. In Chapman, you will find a sentence there which will save the day for you in the exam. Each and every sentence is very important. So there can be other findings like saber shin, etc. This is the Wimberger sign we are talking about. This is from Stat DX. Destructive lesion in the medial tibial metaphysis, through which, same thing which we have already covered. This is the erosion. A portion of metaphysis is still intact here, and this is known as Wimberger sign. And please remember that Wimberger sign, the same sign, is also seen in scurvy. We will come back to this. Uh, so, uh, so this is what I say: develop your eyes, train your mind, and your theoretical knowledge and your differential diagnosis. So, in the exam, what does a differential, what we call uh, I use the word a distinction candidate. What does a distinction candidate do? The differential diagnosis is in the mind, and they go through it and rule out pertinent negatives and positives according to the age and according to the radiological findings. So quickly, let's see this. This is this is the finding in NAI, where you can see this single lamina along the ulna, and classically, uh, of course, there can be other bones also, but in this example, there is ulna. It is not like the periosteal reaction, which was in your case. This is a case of JIA, juvenile idiopathic arthritis. We will not even consider it in our differential diagnosis. This is 2 to 4 years, and the periosteal reaction is along the phalanges. So this is, we'll not keep it in the differential. Now, leukemia can cause moth-eaten bones, and it can cause periosteal reaction. It can be bilateral symmetrical. This is not the age group for leukemia, and the findings were also slightly different. It was not moth-eaten bone. Rickets is interesting. Rickets is anywhere between 3 to 18 months. It can happen. Lower limb first and wrist then. In rickets, it's a pseudo finding. What happens is, if you go back to your normal wear and tear of bone, under the periosteum, new bone formation happens normally. This is normal bone metabolism. So what happens in rickets, that this new bone, which we call osteoid, it is deficient of calcium, and it appears loosened. So the periosteum is high density and the new bone formation is low density, and it can give you a pseudo periosteal reaction. It is a pseudo finding. And please remember, you will not see it in each and every case of rickets. But if you see this case, you can see a bit of bowing, you can see a bit of cupping of the distal metaphysis. So what you have learned from this case, that when you are considering the differential, your description, you have to rule out. Tell the examiner during your description that there is no metaphyseal cupping, no bowing, or there is bowing, etc., etc., pertinent negatives. So this is rickets, again from second part of your Chapman. I'm going to skip it. And then comes this disease, which we will cover once again in the last part of today's session, Kefi's disease. So what is Kefi's disease? Kefi's disease is idiopathic for unknown reasons. The age of onset is anywhere between 9 weeks to 5 months. So usually it is less than 5 months. It can actually happen. It has been reported at birth also. And some people have diagnosed it intrauterine on ultrasound, by the way. But in Kefi's disease, what happens is that for idiopathic reasons, or we don't know the reason, there is periosteal reaction. And with that, there is skin thickening, etc. The child becomes very cranky, and means it must be very painful condition. And it is a self-limiting condition, and usually after a year or so, it becomes fine. There is a type which is more chronic, and it might continue for a few years. Where is the periosteal reaction? Key point is that the periosteal reaction is mandible. If you see here, there is a periosteal reaction along the mandible. Then clavicle. Look at this clavicle and this clavicle, and you can see periosteal reaction there. And then look at the long bones. Periosteal reaction along the diaphysis. So diaphyseal perioaxial reaction, thick periosteal reaction can go to the metaphysis, but not usually to the epiphysis. If you see here, this ulna is involved, this ulna is also involved. So, and this clavicle is involved, this clavicle is involved, and then mandible. And in the exam, you have to ask the examiner. They will show you this long bone, and then you will say that I want to see the mandible. Mandible is very pathognomic sign of this. So remember, Kefi's disease, definitely you can consider in your differential diagnosis. Now, uh, this is scurvy. Now, let's go to the next. This is from your Chapman, and this tells you Wimberger sign. You see, another Wimberger sign. That was syphilis, and this one is what? Wimberger sign, reduced epiphyseal density with a pencil-thin cortex. So, in the patella, you will see it in the patella, because there is osteopenia, the cortex is high density, and this is known as Wimberger sign. In many cases of scurvy, I don't have time to teach you everything about scurvy, but because that we will cover in another chapter, metabolic, etc. But the key point is that in scurvy, what can happen? What can happen? It doesn't happen in each and every case of scurvy. What can happen is periosteal reaction. Why does it happen? Because of subperiosteal hemorrhage. Yeah, you remember that even lack of ascorbic acid, the mucosa starts bleeding, and the patients might come to you. I get a lot of bleeding in the mouth, so ascorbic acid might be less. So when that happens, and this is the type of case we are looking at in the exam, where where first of all, please remember that scurvy cannot happen before 6 months of age, because the the ascorbic acid from the maternal blood goes into the fetus. So first 6 months are fine, then it can occur. So periosteal reaction will occur along the and this will be subperiosteal bone reaction, and it can happen within days, like this. And if you see here, this is the Wimberger sign, and there are other signs of scurvy also. So these can be your pertinent negatives when you are dealing a case in your exam. So this was scurvy. And then comes prostaglandin E1 therapy. So what happens is that these patients, they present with cyanotic congenital heart disease, and they want that the patent ductus, the ductus arteriosus should remain patent, and so that they buy time. At time, these patients are preterm, and they maintain it for a while so that they can do surgeries at a slightly advanced stage. Now, because of multiple reasons, there can be periosteal reaction in these cases, and there is extensive periosteal reaction. If you see this case from radiopedia, bilateral symmetrical, from tibia, fibula, femur, radius, ulna, humerus. Humerus is less, but these are quite significant. Remember, there is nothing in the mandible. So this is uh, prostaglandin 1 therapy. And then comes NAI. NAI is not mentioned in your in the Chapman, but it should be added. In corner fractures in the metaphysis can happen in case of NAI. Please remember that now we use a new term, suspected physical abuse, for NAI. So this is the new word which we use, new term, should I say. So the NAI term has been replaced by suspected physical abuse. So and another one is vitamin A toxicity, which can occur in more than 6 months, and this is along the shaft here, tibia, and along the radius here. So this is the case which I showed you. In this case, if we go back into details, we can see that there is erosions at the metaphysis, medial metaphysis of both tibia, bilateral, and there might be some lucency in the, that metaphyseal band type of finding. Further erosions at the metaphysis, medial metaphysis of femora bilaterally, and incompletely visualized metaphyseal band. With that, there is quite exuberant periosteal reaction bilaterally, and you will start the case like this: that this is a infant which appears to be less than 7 months of age. I don't see any femoral capital epiphysis, and then you describe these findings. Also, just whatever the differential which is relevant in this age group, mention that other these erosions, rest of the bones appear normal in density. Then there is no evidence of Wimberger signs as far as the epiphyses are concerned. There is no Falcon spur. There is no metaphyseal cupping. So indirectly, you're telling the examiner that I did consider in my differential these things, but I have ruled that out. In the end, you will say that the findings are pathognomic for congenital syphilis. End of story. And if the examiner grids you, you will stay firm. So this is congenital syphilis and nothing else. Okay, this was candidate number, sorry, I'm lost.
4.
This 4, okay. So, madam, now you know how to deal with this?
Yes, sir.
Okay, well done. Okay, Aunt Minnie case. What is this?
The leprosy, this look, there's licked candy appearance of the all the toes, in, and there's bony destruction of there's reduced density of all the bones and
Reduced
reduced joints.
density. Are you sure there is reduced density?
No, sir, there's increased density. There are patchy areas of sclerosis, and there's a bony destruction, and there's licked candy appearance of the of second to fifth toes, and with soft tissue swelling, and so
Okay,
this is
thank you. Thank you. Well done. So this is a case of leprosy, and in leprosy comes under the stigmata of uh, uh, Charcot arthropathy. So this is a neuropathic joint. Please remember that Charcot joints or neuropathic joints, one of the pathognomic finding is that there will not be any osteopenia. They will actually have increased bone density. Now, in leprosy, what happens is that the cortexes, particularly of these metatarsals, they appear thin and sclerotic and elongated, uh, as if they as if giving you the appearance of a licked candy. This is known as licked candy sign. So a differential diagnosis of arthritis with preservation of bone density and neuropathic arthropathy, which will be covered in detail on the weekend. Don't miss that. That is one of the differential. Just for your interest, this is from BMJ 1915. And here the paper is written that this is Indian Army soldier. So this is in India, uh, Indian hospital, Brighton, and this was a Jamadar something, Jamadar MS, 1915. So this is the finding, and you can well imagine that it must be have been a big finding because the patient has got soft tissues still intact. When they did an X-ray, this is the diagram which showed sort of, you know, this pointed sclerotic phalanges, so sort of licked candy appearance. And we saw a similar case here in our hospital, which was it was a known case of leprosy. But just to make a point that you can still see because these patients are still there in the population. And so this is what we saw in this 2011 case in our hospital. This we did not diagnose. It was a known case, and it was all treated case of leprosy. Another one which we saw in 2015, by the way, there and you can see this licked candy appearance. You see this licked candy. So and look at the bone density quite increased. Uh, Another thing which can be asked in the exam is this calcification, and I just wanted to show you this from StatDX that this calcification is digital nerves. Digital nerves. So if you see soft tissue calcification, they will say nerves, and this is an example which can happen. Okay, candidate 4. Candidate 4. We are through with the what we call this chapter, infection chapter, right? So the next chapter is a cakewalk. It is, spot diagnosis, which is good. We are so this is your last case, and then I'll go to candidate 5. So give me your diagnosis.
So this is an X-ray pelvis frontal AP view. I can see that on the left side, the left femoral epiphysis appears, head epiphysis appears smaller in size, sclerosed, fragmented, and the underlying metaphysis also appears expanded. And on the left side, the hip joint space appears mildly widened. So this is a case of avascular necrosis of femur head, that is in a child. It is Perthes disease of the left side, and
What is
I'll
this
inform.
lucency? What is this lucency?
Uh, it's a crescent sign,
Okay.
subcon
Okay,
subchondral
fine.
fracture
Well
sign.
done.
Yes.
Well done. So, Perthes disease uh, ranges between 2 and 14, but 5 and 6 is the most common. Please remember 10 to 15% are bilateral, and there can be early signs and there can be late signs. And this was subchondral lucency, which is the crescent sign, which the candidate did very well. In late signs, of course, it can be fragmented head. And it when it is bilateral, the differential diagnosis is very important for your exam. I'll project the differential shortly. This is a slightly more chronic case where you can see this, fragmented sclerotic epiphysis. Uh, this is the type of case which is very important for the exam. I'll come back to this, but this is another one unilateral. Now, if you see here, there is bilateral, sort of symmetrical, uh, fragmented epiphysis. Candidate 4. What is your differential? One differential, of course, can be bilateral Perthes. What else is your differential?
Uh, so, but so this could be neglected slipped femoral epiphysis, um, and so infection,
Which infection?
chronic,
Which infection?
so septic arthritis, and
Examiner is not satisfied, madam.
um,
Anything else?
so bilateral osteomyelitis, or it could be
Okay, I'll take over. This is another very important differential diagnosis for the exam. Very, very important. And irregular or stippled epiphysis. So avascular necrosis, bilateral, we have already covered, 10 to 15% can be bilateral. This is what I want you to remember, congenital hypothyroidism. And I think 1 or 2 sessions down the road, we will cover endocrine on a weekend, in a recording, I mean to say. But this is extremely, so you have to know, you have to know these top 4 or 5. Morquise is an exam case because it can come with central tongues and things like that. Otherwise, this for me is very important, congenital hypothyroidism. So this is an MR where you can see that the normal marrow is lost and there is a bit of a mushrooming, expansion, etc. Thank you, candidate 4. Well done.
thank you, sir.
Candidate 5, are you with us? Let me check. Candidate 5 is co-host. I have made you a co-host now. Candidate
Yes,
5. Okay.
Yes, sir.
So, spot diagnosis, rapid reporting, normal, abnormal.
Uh, Abnormal, sir.
And what is the abnormality?
The tibial tuberosity looks a bit avulsed.
Can that be a normal variant?
Yes, that can be a normal variant also.
You want to change your opinion, or you want to persist with your opinion?
Because I cannot see any obvious soft tissue swelling around it.
So if you see here where my laser pointer is, do you see
Yes.
this? I
Yeah,
don't know if
but
it
I
is
can
projecting.
see that the tuberosity is looking avulsed. So I believe that this is a case of Osgood-Schlatter.
Yeah, you don't use the word avulsed. Avulsed is, post-traumatic. Just say fragmented. Fragmented.
Oh,
Fragmented tibial tuberosity can be a normal variant, but with that, when you see soft tissue swelling or thickening, then you call it. Of course, in your day-to-day practice, clinically the patient will have a pain here. So this is Osgood-Schlatter. Well done. Now, what is Osgood-Schlatter disease? Traction apophysitis of patellar ligament insertion of tibial tuberosity. Traction apophysitis. So, uh, irregular fragmented and adjacent soft tissue swelling. So please remember, fragmented uh, is a normal variant or can be a normal variant when you see adjacent soft tissue swelling, pollen. And on MR, there will be bone marrow edema at this site. This is another case where you can see the similar finding where fragmented tibial tuberosity and there is a bit of soft tissue swelling. And this is an MR where you can see on this stir sequence, there is a bit of edema at the insertion site, and maybe a bit of high signal within the patellar tendon. Another disease here, which is known as Sinding-Larson's disease. Here, if you see, there is fragmentation of the inferior pole, and on MR, this is a different case, by the way, this is a different case. We can see that this is the patellar tendon, and this is the origin at the patella where there is a lot of edema. So what is this? This is traction tendinitis at the inferior pole of the patella. And on X-ray or a CT, there can be calcification or ossification of proximal inferior patellar tendon. Actually, this thing is the patellar tendon which is ossified, which gives you this appearance. And when started my radiology, if you read old textbooks, uh, the first book which I read was 1987 Saturn. They had mentioned this at avascular necrosis. Can you imagine? So the concept at that time was that there is avascular necrosis of the inferior pole of the patella because MRs etc. were not available, and later on people understood that actually it is just traction tendinitis of inferior pole of the patella, and within that tendon there can be ossification, which gives you this appearance, where gives you this fragmented appearance, etc. Sending Larsen disease. Uh, Normal, abnormal, your rapid reporting over.
Mm,
Candidate 5, are you with us?
Yes, sir.
Normal, abnormal.
Just looking at um, the second metatarsal head looks a bit flattened to me,
Right.
and really sclerotic as well. It could be Freiberg's.
So the candidate has pointed this out, and this is Freiberg disease. So sorry, this was our case where we can see it's a classical rapid reporting case. And by the way, rapid reporting cases can also come in the Viva. Remember that. And so this is it. What are the findings? Subchondral insufficiency fracture secondary to osteonecrosis of metatarsal head. This is what happens. Second metatarsal head 68%, third metatarsal head 27%. And there can be motile sclerosis. There can be concavity of metatarsal head. Look here. Look at this. So develop your eyes on this finding. And if you get this in the exam, you should understand that this is also Freiberg disease, where there is a concavity here, as if there is an erosion here. This one, all of this is sclerotic and flattened. But this one, this concavity, develop your eyes on this one. Of course, on MR, there can be bone marrow edema. And so this was the case which I showed you, and this is a more advanced case, which is quite obvious that this is Freiberg's disease. Normal, abnormal.
So abnormal. Then the navicular bone um, looks small in size and looks a bit sclerotic as well. So probably it's osteochondritis of the lunate. Oh, sorry, navicular.
Navicular. So this is Fowler's disease, avascular necrosis, and please remember it happens in childhood, but it can also happen in adult. And ultimately, in chronic conditions, if chronic avascular necrosis, it can be very flattened and small in size, like this. Look at this one, how it is. Fowler's disease, referring to childhood onset osteonecrosis, right? But Muller-Weiss syndrome is the adult counterpart of navicular bone osteosclerosis. So it can happen even if you don't remember the names. Nobody's asking you the names, but please remember the concept that Fowler by definition was childhood, but it can happen in adulthood. 4 to 6 years. Vapor-like thin fragmented patchy sclerosis, soft tissue swelling can be there. Yes, candidate 5. Can you describe this for me?
So there is a focal kyphotic deformity in the dorsal spine, along with the slight irregularity of the end plates of few of the vertebral bodies. So besides this, I'm also suspecting small Schaumer's nodes at few of the vertebral levels. So I believe that this is a case of Scheuermann's disease.
Excellent, well done. So, what is Scheuermann's disease, also known as adolescent kyphosis? So the concept behind it is that this is the proposed mechanism is that there is avascular necrosis of ring epiphysis of vertebra. So there is a ring epiphysis at the end plane, and this is also known as juvenile kyphosis, uh, also known as adolescent kyphosis. And so when there is avascular necrosis of this, then the intervertebral disc, it it goes into the end plates. It herniates into the end plate. Chamorro's node, by definition, is what we call intravertebral disc herniation. So this word should also be in your vocabulary. Intravertebral disc herniation is the same thing as Chamorro's node. And so if you read the nomenclature of disc according to the many societies, this is mentioned there, intravertebral disc herniation. So because of softening of bone. Now what happens is adolescent means the name tells you it always happen in adolescent age group. And there will be multiple Chamorro's node, and anteriorly the vertebrae will be more compressed as compared to the posterior side, overall giving a kyphosis. By the way, it's a self-healing process, and gradually the patient becomes normal. So usually it is self-limiting. At times braces etc. are used to give support, but the prognosis usually is quite good, with greatest narrowing anteriorly. If you see here, so the greatest narrowing is anteriorly. This was our case, and you can see that the narrowing is more marked, and the anterior portion of the vertebra is also reduced anteriorly. Surgical treatment is only for more than 75% of kyphosis. Initial treatment including observation and bracing. Observation is no treatment, by the way. So MR, same. This is a 14-year-old with Scheuermann's disease, and you can see the same finding on this MR. So MR is also an exam case, remember. And if you see the end plates, or look at the end plates, and look at these intravertebral disc herniation, and look at the anterior portion, the height is reduced as if there is a compression factor. So this is Scheuermann's disease, and more than 3 vertebral bodies, by definition, you see, this is from your book, multiple collapsed vertebrae, Scheuermann's disease, children and young adult wedging of more than 3 adjacent vertebrae in lower thoracic spine with irregular end plates, displaced narrowing, and kyphosis. Yes, please.
So in this case, the diagnosis is already written. So
what happens here?
So in this, there is erosion seen at the medial tibial upper end of the tibia, and the epiphysis projects over it. So that
Erosion.
appearance.
What is the pathophysiology of Blount's disease? What is the pathophysiology of, let's say,
it is basically osteonecrosis.
Is
the
it
upper end.
Okay, in mid-lung deformity, what happens?
So in mid-lung deformity, the inner third of the distal radial epiphysis is deficient.
Right. So something like that happens here also. What is the connection between mid-lung deformity and Blount's disease for your 2B exam? Hint, both of these can be seen in a condition together. No?
No, sir.
Turners.
Okay.
So basically, you see, this is the medial epiphysis of the tibia, and that is, deformed or whatever, and it gives you this kind of appearance. This case is more marked. This one is less marked. The only way it can come in the exam is, as a stigmata of Turner syndrome. Turner syndrome is important for the exam, particularly vis-a-vis two differential diagnoses. I think we have already covered it in congenital. These metacarpal, particularly the fourth metacarpal, can be smaller in size, and that's a very important differential. Metacarpal, small metacarpal. Second thing is mid-lung deformity. Now, if you see here, look, the mechanism is that the medial portion, you are absolutely right in your concept that the medial portion of the epiphysis of radius, it is not formed. And because of that, there is subluxation of the carpal bones and there is subluxation at the distal radio-ulnar joint. It's a bilateral finding in this case. In Turner's, Blount's disease can also happen. Otherwise, there is no importance of Blount's disease, but I just wanted to show you the cause of Turner's. This thing we have already covered previously. And this is the differential diagnosis for mid-lung, and Turner syndrome is one of them. Spot diagnosis, what is happening here?
So scaphoid waist fracture with avascular necrosis of the proximal pole.
Excellent. So we have got a waist fracture here, and with that there is sclerosis here, means that there is avascular necrosis of the scaphoid. And on this is a different case in which we can see avascular necrosis of the proximal pole, low in signal here and slightly high in signal here of the scaphoid. If you just concentrate on this X-ray for your rapid reporting, normal or abnormal, just consider this one, nothing else.
This is abnormal.
And what is happening?
I think lunate avian.
Excellent. Lunate avian. And by the way, in your exam, this can come as a lateral. Please remember that three bones are in one line on a lateral wrist X-ray. One is radius, then is lunate, and the capitate sits in this cup, which is the cup of the lunate. And you can see that the lunate is compressed, it is sclerotic. So this is known as in-box disease. Osteonecrosis of the lunate, sclerosis and flattening, and this is another example and another example and another example. Okay, from here we come to bone infarct. Now this is interesting. Avascular necrosis versus bone infarct. And this is very interesting that we have, just complicated the matter for ourselves. We use the word avascular necrosis when epiphysis is involved or the end of the bone is involved, subarticular portion of the bone is involved. We use the word avascular necrosis. And when it is any other, part of the bone, we use the word bone infarct. When lesion is not in subchondral, you call it avascular necrosis. Otherwise, we call it bone infarct. Having said that, if you say something which is subchondral as a bone infarct, absolutely no issues because it is a bone infarct. So, and this example tells you that this portion here is not subchondral. So, and this one is subchondral. So, key point is that bone infarct is the same thing as avascular necrosis. Now, this is a viva question, so you have to have a clear-cut idea about this. And this calcification is a viva scenario. Calcification on a plain film and double line sign on an MR T2 weighted sequence. So, bone infarct will show calcification, and this calcification is so dense that it is denser than the bone, so it projects, and this is usually serpiginous, calcification, and sometimes it can be amorphous sclerotic calcification. You have to differentiate it with calcification of an enchondroma, which is a cartilaginous tumor. A cartilaginous tumor like an enchondroma will have ring and R for punctate calcification. I'll show you a few radiographs. And this scenario is important for your exam. Double line sign. What is a double line sign? And this is an exam sign. They will ask you in the exam. First of all, remember that this is on a T2 weighted sequence. It is seen on a T2 weighted sequence. There is an outer rim of low signal, usually serpiginous, which is the demarcation between living and necrotic bone. And then there is an inner margin of bright line. What is that bright line? That bright line is granulation tissue or inflammatory response. And internal to that will be either fat, or if fat is not present, it is all necrotic, then it will be lost. Double line sign, by definition, is a sign seen on T2 weighted sequence. Outer, and this is what they will ask, what is this? How do you explain this? The outer line is the demarcation between living and necrotic bone. Inner is granulation tissue, which is bright on T2 weighted sequence. You should know the etiology of bone infarcts, things like sickle cell disease, steroids, things like Cason's disease. All of these are very important, and there is a huge list. Now, this is this. Can you, candidate 5, can you
Yes.
describe this for me?
So
Here on
in this case, there is bilateral avian, as evidenced by a mild collapse of bilateral femoral heads, and along with that, I can see geographic areas in affecting the bilateral femoral heads and the subchondral location, present sign on both sides.
right. So here you can see that double line sign which I was mentioning. For example, this line where I am pointing out, this is low signal, and the inner one is high signal. Here you are. Outer is low signal, and the inner one is high signal, and this is what the double line sign is about. And this double line sign is always seen on a T2 weighted sequence. Normal, abnormal.
Um, I think. So can you change the window a little bit? I can make.
No. You can see the finding on this window. I'm on a PowerPoint. I cannot change the window. Okay. This is not a DICOM. But you can see the finding.
So maybe something at the medial. Medial femoral condyle is looking.
Medial femoral condyle. What is the abnormality? So you are right, but what is the abnormality? What will you put in the exam?
Maybe some osteochondral.
Excellent. If you look carefully, now this is the outline of the cortex. This is the lateral femoral condyle. Here, just trace this. And then there is a line which is normal, but anteriorly you see this. There is a defect there. There is something is missing there. So this is an osteochondral lesion. And osteochondral lesion, which actually you can see here where I am pointing out on a lateral. This osteochondral lesion, what will you highlight to the clinicians about this osteochondral lesion?
So I believe that this is unstable because there is a lucency surrounding it. So probably it's a.
Excellent. Well done. So this is a rim sign, which is a sign of an unstable osteochondral lesion. Give me spot diagnosis. What's happening?
So bone infarct affecting bilateral femurs and tibia.
Yeah. So if you see here, these are bone infarcts which are happening bilaterally, and this is the type of plain X-ray which you have to develop your eyes on. If you look carefully, look at the calcification. This calcification is that serpiginous type of calcification, which of course correlates with the findings on the MR. And on the other hand, at calcification. This is a enchondroma. Bone tumors will be covered separately. Uh, enchondroma is a unique tumor where you find cartilaginous matrix in a long bone. In a short bone, as in hand, etc., you will see a lytic lesion. But in a long bone, usually you will not see a lytic lesion. On the other hand, you will see chondroid matrix. And the chondroid matrix is made up of calcification on a plain film. And it will be high signal on any fluid sensitive sequence on MR. But coming back to the plain film, chondroid matrix will be calcified. And look at this calcification of chondroid matrix will be uh, ring, arc, punctate, ring or arc or dots, that kind of a thing. Incomplete rings, arcs, uh, complete rings, arcs or punctate type of calcification. This is a case of malignant transformation of an enchondroma. This is an exam case. We will cover it separately, but why I am showing you, they can show you a malignant transformation of a bone infarct. Please remember, bone infarcts can malignantly degenerate. And on the other hand, enchondromas can malignantly degenerate. And in this particular case, this is punctate calcification. This becomes a story. This case is a story. It tells you a story. The story is that originally this lesion was an enchondroma, and then it develops an lucency. If you see the cortex, this cortex is eroded, and there is a criteria which I will cover again when we do bone tumors, where more than one fourth or one third the thickness of the cortex is eroded, or the height of the lesion, etc. So it is causing, and you will say that this is malignant transformation of enchondroma. Key point to remember is that this is an enchondroma because of the pattern of calcification, which is ring and arc, which is like this. So, and uh, on the other hand, classical serpiginous calcification uh, can be in bone infarcts, which can also malignantly degenerate. Okay, candidate 5. What is happening?
Mm,
What is happening?
I think humeral head avian.
Right, and what is happening here?
Um,
The projection is not very good, so let me give you this thing.
Bone
Same patient.
infarcts in the knee as well, and I mean in the distal femur.
So bone infarcts at the head of the humerus, as well as multiple bone infarcts here. What can be the etiology? What can be the causes? So the viva can be on the causes.
And for bone infarcts at multiple sites, it can be because of drugs. I mean, NSAIDs, steroids intake, or it can be because of sickle cell, or it can be because of it can be because of gauchos also. So there's a lot of differentials which can be there and which needs to be clinically assessed to reach to a certain diagnosis.
Right. This one was actually Cason's disease. This is a Cason's disease, and that should be in your differential. This patient was a deep sea diver actually. And so in Cason's disease, this is also known as bends. Basically, what happens is that when you go into depths, more than 3 atmosphere, which is more than, let's say, 99 feet, at every 33 feet, the pressure increases by 1 atmosphere, which is 760 mmHg. So at 66, it becomes, at 33, it will become uh, 1 atmosphere, then 2 atmosphere. Correction, at surface level, it is 1 atmosphere. At 33, it will be 2 atmosphere. At 66, it will be 3 atmosphere. At 99, keep adding. This chap, I was talking to him, he had been diving till 180 feet, by the way. And the is not diving at 100 feet, 180 feet. Uh, he the problem is that when you go into this kind of depth, then nitrogen it gets dissolved in bone marrow, and if you lose your height, that is the main problem. Quickly, you cannot. If you decompress quickly, then what happens is that nitrogen is released from the bone marrow. It goes into the vessels, and it will cause, emboli, should I say, and which causes these pattern. So Cason's disease should be part of your differential. Uh, this is your last case, and then we will go to candidate 6.
Okay.
What is your diagnosis here? Okay, go through your findings, should I say.
In this 3 months old child, x-rays which have been provided to me, I think there is some periosteal reaction which I can see in the right distal humerus, and in the ribs, uh, in the clavicles again I can see that there is some periosteal reaction. So um, so considering the periosteal reaction affecting various parts of the body, I can see some periosteal reaction in the um, in the I think radius as well, lower down. So um, I believe that this could be a case of um, uh, considering the age of the child being 3 months. I was thinking on the lines of infantile cortical hyperostosis, but the age is little less for
Why do you say it is less? Why do you say it is less? What is the age of infantile cortical hyperostosis?
I believe it happens more after 3 months.
No.
Okay.
So,
okay, it will happen in utero also. Okay. So I believe.
So what is the feedback? You see, the feedback is that your theoretical knowledge, how important it is. You picked up finding beautifully, but you were not able to diagnose it for the simple reason that you did not remember the age of Yafes disease. Yafes disease,
Yes.
actually, I went through it when there was a case there earlier in the day. Anywhere between 9 weeks to 5 months. 9 weeks means 2 months to, but I also told you that people have actually diagnosed it. Some people think that it can be at birth, and some people have claimed it to see it on ultrasound, by the way, mandible, thick mandible, things like that, in intrauterine. So, having said that, once you pick that up, clavicle, and then look at the mandible, must look at the now stretch of imagination that there is some soft tissue, and you will ask the examiner that I want to see an oblique of the mandible. There is nothing else, if you ask me, which can be in differential diagnosis in this. This is what we did this exercise earlier in the day. Now, if you look at the pattern of periosteal reaction, look at this board. This is diaphyseal mainly, and this is diaphyseal mainly. And that also I told you. So there is nothing else in this thing which should be in the differential. It's a pathognomic finding in this particular case. Yafes disease, uh, mandible clavicle show diffuse periosteal scapula. So the key thing is we have already covered it. So I told you it can be self-limiting, etc., etc. Uh, age of 9 weeks to 4 months. Here you are in utero diagnosis. So people have also diagnosed it in utero. And so this is classical diaphyseal, and this is mandible in. So these are from STAT DX, from other examples. This is, I think, the same example with mandible, 1 month. This is 1 month old. You see, 1 month old, Yafes disease. This is from STAT DX. And this one again diaphyseal. Candidate 5, thank you very much. Well done. You've done very well. Candidate 6, are you with us? Let me check candidate 6. You are now a co-host.
Good evening.
Okay, good evening. Good evening. Well, so you are still around. That's very good. So this is Kefi's disease, in which serial radiographs shows you how it has become normal, a bit of modeling deformity, otherwise it has become normal in serial radiograph. Another example where we can see that there is periosteal reaction, clavicle, stretch of imagination, something is happening here. You will tell the examiner, I want to see the mandible. If the examiner has got the mandible, will show you. Look at this case. Now, these are the teeth. Actually, this where I'm pointing out is the mandible. And this thing, everything is new bone formation. So very, very thick mandible. So you have to ask for it to the examiner. Okay, over to you.
Yes, I have been presented with a frontal skull radiograph for an 71-year-old male patient. The first observation, I noticed that there is diffuse thickening of the skull vault of this patient. I cannot see any thickening within the mandible. Also, I can see the orbital cavity appear within normal. In my routine practice, I want also to check the lateral view for this patient if available. Yeah, in this lateral skull radiograph, I can see that there is a well-demarcated area of lucency seen in the frontal aspect of this skull. I can see that there is two metallic-like structure.
Yeah, don't worry about it. That was a bandage applied.
Okay.
What is your diagnosis?
My diagnosis, it could be those changes of metabolic lesion. I will put on my differential diagnosis Paget disease, which can cause thickening of the skull and can also cause the lucency lesion in the frontal aspect.
Excellent. Well done. Well done. So this is Paget's disease, and in Paget's disease, what can happen is that there can be, there are three phases actually. One is the lytic phase, which is very active phase. One is the mixed phase, and one is the sclerotic phase, which is very chronic. Key point is that it will cause thickening of the calvarium, and so this calvarium thickening is there, and there is a lucency there. We call it osteoporosis circumscripta, and this is classical Paget's disease. Paget's disease should be discriminated with fibrous dysplasia, and in fibrous dysplasia, usually calvarium is not as much involved as the base of skull as well as the facial skeleton. But I'm not covering fibrous dysplasia right now. We will cover it more elaborately in head and neck. So this is a case of Paget's disease. Another case which can come in the exam, and when you do a bone window, only then, so the examiner can show you some finding, and Paget's disease as an incidental finding. When you say that I want to do on a brain CT, I want to check, or in my usual practice, I check it on a bone window, you might find this. Just wanted to show you a gross case of Paget's disease. Whole of the calvarium is involved. Over to you, candidate 6. Your case, please.
Yes, I have been presented with frontal and lateral radiograph for the leg. I can see that there is lucency seen involving the proximal metadiaphyseal of the right tibial bone, and there is a sharp transformation into the normal bone distally, giving the appearance of blade grass line. Also, there is no cortical destruction. There is no cortical bone matrix and there is no periosteal reaction. My differential diagnosis, this is a classic appearance of blade grass sign and representing
Excellent, well
Paget
done.
disease.
Now, the lytic phase of Paget's disease, at times, those candidates who haven't seen those, and this is the example. Paget's disease, by definition, is a disease in the long bone which goes to the subarticular portion of the bone. So remember that, subarticular. One exception is tibia. In tibia, it might go just to the tibial tuberosity. At times, it can extend to the subchondral portion, but it goes till the tibial tuberosity. So otherwise, in long bones or tubular bones, you will see it go till the end of the bone or subchondral portion or the epiphysis, whatever you want to call it. Now, in this particular case, if you see here, there is a lucency. And this lucency extends anteriorly in the cortex, blade glass appearance, flame shape appearance, and it is lucent. So the eye knows, I see what the mind knows. And with that, you can imagine that the anterior cortex is thickened also of this lucency. Paget's disease is, there is expansion of the bone and there is the mixed phase. So remember that. Now look at this from ACR, American College of Radiology. This is lucency in the cortex anteriorly, and how it has become more coarse. As the time goes, it has become thick, coarse, and there is a bit of bowing of bone also. What is the interval? 8 years. In 8 years, this is what has happened. Oh, the projection is extremely, I think, not a good one to show you on this PowerPoint because it has become very, very high density. Having said that, it will be a bit unfair, but maybe you can make up. Can you just concentrate on this humerus? And anything wrong?
Yes, I can see that there is, in comparison with the other left humerus, I can see that there is cortical thickening involving the proximal part of the right humerus, and also I can see that there is increased trabeculation of the proximal right humerus, and I can see that there is cortical periosteal reaction is noted. I want to see if this patient is known case of Paget disease. With this finding, it could be representing a malignant transformation of the Paget disease.
Patient is asymptomatic as far as right humerus is concerned, no pain or anything. How can you explain that finding?
It could be due to radiation, maybe from a previous tumor or something.
Okay. Now, this patient, this was an incidental finding on this chest X-ray. The patient had some other symptoms for which chest X-ray was done. Now, if you look carefully, what has happened? We can see this coarse trabecular pattern, we can see this lucency. If you compare, I don't know if it is projecting for you people or not. If you compare this cortex here and compare it with this one, you will agree that this is thickened and it is going till the edge of the bone. This lucency which gives you the appearance of a periosteal reaction. Your thoughts are absolutely fine that I will be worried about malignant transformation. But once I tell you that this patient is asymptomatic because no pain, no nothing, this is that lytic phase. Just like your case here, lucency, there is a bit of lucency, just like this case, there is a bit of lucency which is explainable on grounds of the normal pathophysiology of Paget's disease. But the way you tackle it was absolutely fine. So it can be, it is what we call a pseudo finding. You remember rickets in which there was a pseudo finding of periosteal reaction. So this is something like that. Look at this Paget's disease, and here it is metatarsal, first metatarsal, and again it has gone all the way to the end of the bone. Another case of humerus, and here it has gone till the end of the bone, subchondral portion, expansion, etc. Yes, please. Anything in the vertebrae?
Yes, I have been presented with the frontal abdominal radiograph for a 60 years patient with a history of weakness in legs. I am checking now the vertebra. I can see that the pedicles appear visible in all vertebral levels, but in the upper lumbar vertebrae, I can see that there is sclerosis. Sorry, in the lower thoracic vertebra, I can see that there is diffuse sclerosis and loss of height.
If you concentrate here, what do you think about this vertebra?
Yes. In this vertebra, I cannot see the pedicle very well.
What about the size, the medial dimension?
Yeah, it sure reduce in the vertebral height in comparison with the rest of the vertebrae. This is a T1 sagittal MRI for the same patient. I can see that there is diffuse increase in T1 signal intensity within this vertebral body in comparison with the rest of the vertebral body. This, because of the high signal, it could represent bone marrow changes. Because this is a T1, it could be due to patty replacement. It cannot be calcification because it will be darker in T1. It also involving the posterior element. I think the posterior element of this L2 is also involved. So other differential diagnosis, it could be due to blood, such maybe could be due to benign tumors such as hemangioma. It could be bright.
So what is your diagnosis?
I think it could be due to metabolic involvement.
Okay.
Or
basically, what is happening? Look at the size of the lesion. Look at the size, AP dimension. Look at the AP dimension. What happens is that Paget's bone is not a normal bone, and Paget's can cause insufficiency, fractures, etc. We know that it is a soft bone as compared to a normal bone. But look at the size. Size is key, and you will agree that this AP dimension is increased. And this is a case of simple Paget's disease. If you see here, look at the mediolateral dimension. It is slightly bigger. It is a subtle finding where just from here to here versus from here to here, and you will agree that this is more. But here that is confirmed. Now the marrow is normal, and you did well where you just describe it. It's normal. Low T1 is bad. This is high T1, which is good marrow. So the finding is just that this is Paget's disease. End of story. Now this is another. Can you describe it? This is Paget's disease, but just describe the findings for me.
Yeah, I can see that there is enlargement of the vertebral body in comparison with the adjacent vertebra, and it showed sclerosis and also showed central bone marrow lucency, giving the appearance of empty frame sign.
Which sign?
Empty frame sign.
Empty frame sign. Okay.
Yeah.
The word which we use is picture frame vertebra.
Yeah.
So if you see, this is sclerosis. There is nothing else in the world which will cause this. where, there can be sclerosis here and here, but here and here, there is nothing else. This is known as picture frame vertebra, and this is Paget's disease. The size is also increased, and the same disease can extend to the posterior part also. There are other, Ruger-Jersey spine. This one is renal osteodystrophy, where you see this, again, Ruger-Jersey spine, etc. This is Cushing syndrome, where you find osteoporosis and sclerosis. In Cushing syndrome, lot of new bone or exuberant osteoid tissue can be formed. But the main point here is the picture frame vertebra. So as I was telling you that a Paget's vertebra is not a healthy vertebra, so it can collapse. But the key thing they will show you in the exam, the key thing will be size. And why has it collapsed? What do you think? There is no history of trauma, and the answer is that actually this was inherent Paget's disease. This is from Stat DX, and this is same thing, where the marrow is fine because this is T1, but the vertebra, look at the AP dimension. So also look at the size. This is another one where the cervical spine, anterior body, as well as the posterior elements are involved. Normal, abnormal. What do you think? The
I think this is abnormal. The abnormality, I can see that there is thickening of the iliopectineal line on the left side in comparison with the right side. And also I can see that there is subtle sclerosis seen involving the left hemipelvis bone. Appearances are classic for this of Paget disease.
Excellent. So here, if you see here, look at it, compare this with this, and you will agree that there is sclerosis and coarse trabeculae. And just to make a point, that on MR, how big the finding is, it was Paget's disease. MR signal on Paget's is, it all depends on the stages, etc. Nobody will show you an MR for Paget's unless there is malignant transformation. But the point is that you have to develop your eyes on a plain film. And please beware of nuclear scan, because they can show you PET scan, they can show you bone scan, in which there will be multifocal uptake. And the key thing which they are asking you to, you have to ask for plain film. And once you ask for a plain film and correlate, then you will make the diagnosis of Paget's. Same thing for fibrous dysplasia, because fibrous dysplasia can also show uptake on bone scan and PET scan. Ask for a plain film and then reach a diagnosis. Fibrous dysplasia will be young age. This, of course, will be old age. I just wanted to show you a Paget's. Now we are covering Paget's, which is the last thing for today. But I just wanted to develop your eyes on this appearance, because in UK, Paget's disease is quite, I should say it's not very uncommon. But in some parts of the world, you won't see so much Paget's. But I just wanted to show you this gross case of Paget's. Don't get confused about it. This is Paget's and this is diffuse Paget's. And in this Paget's candidate, what do you think is happening here and here?
I think there is secondary pathological fracture is noted.
Excellent. In Paget's, what happens is that pathological fractures, because it is insufficiency fracture, please remember the concept of stress fracture versus insufficiency fracture. Stress fracture is abnormal stresses on normal bone. Insufficiency fracture is, normal stresses will cause a fracture on abnormal bone. So this is insufficiency fracture, and one of the fractures which you will see is incremental fracture. It is not a complete fracture, it is just causing part of the anterior cortex is involved. It can convert into a full-blown fracture, but right now it is an incremental or incomplete fracture. This is multiple insufficiency fracture of tibia. I want also you to differentiate, develop your eyes on this versus this. Candidate 6. This is a 12-year-old. This is a 69-year-old. This is Paget's disease. What is this?
Yeah, and this 12-year-old frontal pelvic radiograph, I can see that there is patchy areas of sclerosis seen involving the pelvis bone, and also I can see that there is lucency and cortical destruction seen involving the right femur bone. Because this is a very young patient, this cannot be a Paget disease.
What do you call it? I want you to use a word, and that's I'm
This
waiting for
could
that
be.
word.
Sorry.
I'm waiting to hear a word. Let me tell you that everything is abnormal.
Yes.
Whole of the marrow is abnormal. This femur is abnormal. This is abnormal. This is abnormal. This is abnormal. Everything is abnormal. Use a word. How will you call it? No?
Sorry, no.
No? Moth-eaten bone.
Okay. Okay.
And I wanted to show you moth-eaten bone. You know, this is basically moth-eaten bone is a gross finding. And it will happen with neuroblastoma, metastasis, leukemia. These two are very important and you know, bad things actually, moth-eaten. And diffuse abnormal. So, of course, this one is coarse trabeculae. There is expansion of the bone. Age is different. This one is a moth-eaten. And the differential is, you know, terrible. Neuroblastoma mets versus leukemia is the most common. So this is moth-eaten bone. This patient is a known case of Paget's disease, right? We know that in the right hemipelvis there is a bit of chronic Paget's disease. The patient has developed right hip pain. This is the second last, I think, case of the day, and then you will see the last case. Can you describe it? What is happening?
Yes, I can see that there is cortical thickening and trabeculation seen involving the right hemipelvis of this patient. I can see that there is also sclerosis or matrix seen in the area of the sacroiliac joint. There is also involving of the sacrum, and in my routine practice, because this is a patient known case of Paget, I will compare with the previous images, and because of the clinical history of pain, I will think about malignant transformation into osteosarcoma. Yes, in this axial images of the CT scan, I can see that there is cortical thickening. I can see it in the last image. The image on the right bottom, I can see, left bottom, I can see that there is a matrix, which is mostly representing osteoid matrix, which representing the osteosarcoma changes of the Paget disease. I can see that there is also bone destruction, and also.
Thank you.
Yeah.
Excellent. Well done. Now, if you see here, what is happening, this deformity, etc., is all explainable because of the chronic Paget's disease. On this X-ray, the key finding is here. Now, if you ask yourself, this is the SI joint, this is the upper portion of the sacra, you know, the iliac bone. What is this? You know, compare it. This versus this. So there is, you know, osseous tissue here, which is abnormal osseous tissue. So candidate did well. And then on this CT scan, we can see that there is osseous, but the key finding remains the same thing, that this is the L5 vertebra, and around it, there is soft tissue ossification, you know, osteoid matrix should not be there. So there is malignant transformation, and this is an osteosarcoma. They will ask you which tumor, and this is osteosarcoma. Well done. That was last case of the day.
I have been presented with...
Just 1 second. I know that there is an osteochondroma here. I am not at all interested in this osteochondroma. Don't even display it. Over to you.
Okay, I have been presented with frontal, abdominal, and pelvic radiograph for a 20-year male patient. I can see that there is multiple surgical clips in the right side of the pelvis. Other than that, I can see that in comparison between the sacroiliac joints, I can see that there is loss of the or changes of sacroiliitis seen on the right side, and I can see that the sacroiliac joint is normal on the left side. Because this is unilateral changes of sacroiliitis, I will see if the patient has constitutional symptoms such as fever and pain, and this will raise the possibility of sacroiliac joint infection.
Okay, can I stop you? There was no pain or anything. I want you to tell me what is the difference between this iliac bone versus this iliac bone?
Yeah, I can see that there is decrease in the size of the left sacral and iliac bone in comparison with the right side. Because of that, I will see if the patient is a known case of paraplegia or have any spinal tumor before.
No, not paraplegia, no spinal tumor.
Okay. So I will compare also with the previous images to see if this is presented before or not. I will suspect congenital anomalies or congenital disease such as polio if it is presented in the
Nothing
images.
like that. Nothing like that.
Okay. I can see now that the sacrum is not
You see
represented
these
in this.
vertebrae.
Yeah.
Something. What is the difference between this side versus this side?
I think there is
Or
decrease in the size, decrease in the height in the left side in comparison with the
excellent. Excellent.
Right.
Yeah. So how do you correlate all of these things with this?
Maybe a congenital disease.
Okay, fine. So this is a classical story film. This is a classical exam case, story case. Story tells you a story. The story is written there. Let me tell you first of all, there is a differential diagnosis in your book 14.4, asymmetrical maturation. And by the way, congenital hyperemia can cause, hypertrophy. So, for example, in JIA or hemophilia, etc., the epiphysis will become enlarged. So, on the contrary, is this thing here, hemiatrophy or localized atrophy, and this is an exam case. It has it you must develop your eyes on this. Radiation treatment in childhood. Radiation treatment in childhood. This is what it causes. So, what happens in radiation treatment of childhood? Radiation, it causes a sort of a small vessel ischemia type of a thing, and that is why a vasculitis type of a thing, small vessel, and that is why there can be atrophy. If you stretch your imagination, now what is happening? This patient had Wilms tumor. So, so what is happening is that this tells you surgical clips. So there must be some lymph nodes which they have removed. So the tumor was on this side. This is the the radiation portal. This is the radiation portal. After surgery, they have also given radiation because there were lymph nodes, etc. And because of that, there is atrophy of this, and there is the adjacent side of the vertebra, they are disproportionately involved. So you can imagine that this was the radiation portal. This is a classical exam film, a story film, and you can only diagnose it if you remember this concept of hemiatrophy. Candidate 6, well done. You did very, very well. Well done.
Thank you, sir.
So,
Thank you.
yeah. So once again, the for next 22nd. Don't miss this. And I will give you another what we call next time a questionnaire where you, if you want to be part of the team for future sessions, uh, you can be part of our team, and you will be given chances to project or present your cases also in future. We will make it as an ongoing endeavor. The main concept of all of this is to learn from your mistakes, and I will show you cases from my own experience, the mistakes which I have done. I will tell you and what I have learned from them, and it's a beautiful concept for your 2B exam also. I will select cases from the cases which we we have learned from in our department in the last 10 years or so, cases which are good for your 2B prep also. So I will show you it. You will find it very interesting. And then I want you to be part of our team also for this. So those of you who have not filled it up, if you can just fill in this questionnaire, 10-second questionnaire, and final announcement is about this course, which is a Viva course, 31st of August and 1st September in Rashid Hospital. If you want to attend it, this is the email dubaifrcr@gmail.com, and that is about it. I think we overran by about half an hour, but it was too much to cover. I hope you found it useful. This was A to Z, 2 chapters we covered. They were easy chapters, but there is a lot to cover in a chapter. So on this weekend, I think we will show you arthritis. That's a big one. Arthritis is very important, so don't miss that. And the session after, I think, will be tumors, which is again very, very important. Okay, then, thank you. And if there is any comments or anything, I will be with you for the next 5 minutes. Second case of obliteration of iliopsoas fat, did not get it. Iliopsoas. So what happens is that distension is what we were talking about. Obliteration is a word which we use when you don't see something, and distension is where it is when there is effusion in the joint, there is distension of fat plane. So this is what it was about. I think this is what you wanted to ask. Basically, it was not obliterated; it was distended. There is another case, GCT with malignant can put in your osteomyelitis and destroyers. How to differentiate signal of, yeah. So GCT, you can say that I can with malignant transformation. However, there is no marginal sclerosis, and it is not very eccentric, etc. Whatever, yeah, I will accept that. But there were some things which were against it, as the candidate also pointed out. How to differentiate signal of disc versus discitis in postpone. So disc signal, basically, if you see fluid signal on T2, that is what we were talking about. In every case, you will not. Disc will be, if you see fluid, then you will say that this is abnormal. Osteosarcoma, malignant, Paget's differential. So osteosarcoma, malignant Paget's, the main point was that there was soft tissue ossification. There should not be any soft tissue ossification, which was next to the lumbar vertebra, and that told us that there is something wrong, and there is malignant transformation, and this is an osteosarcoma. So GCT or malignant transformation of a GCT, if you say that, because there was periosteal reaction, usually there is no periosteal reaction. I will accept that if you say that. Spina ventosa will be seen in childhood. Paget's disease will be seen in old age. There is no way that you are going to confuse between the two. These are usually short bones, tubular bones of the hands, and Paget disease is different distribution. Normal disc signal will be high and discitis would also be high. You know, normal disc, you are talking about normal disc as in annulus fibrosis and nucleus pulposus. Nucleus pulposus will be high. That will be a very healthy disc, and it don't confuse it with a high signal of a spondylodiscitis, where the disc will not be healthy, it will be abnormal, it will be reduced in height, etc. You won't find that normal signal. It will be different signal. It will be, and this is what we are talking about. Having said that, every case is not like that. Every case will not have a high signal. So it is just a finding which you will see in some of the cases. Last case was hemiatrophy in the surgical field, where radiation was given because of Wilms tumor, which included the ilium and the left side of the vertebral, the vertebrae, and that is why they were smaller in size. Okay, then, thank you very much.